Today we're talking about minimally invasive surgery, both with and without a robot to guide the surgery. And just a little bit about my background. I started practice in 1997 and very quickly became interested in minimally invasive techniques. In 2005, we broke off, and I broke off and started my own center, and have grown it from them with a focus of being very minimally invasive in our activities and doing some design development. My practice is really 100% spine. It's mostly degenerative, about 15% cervical. Up until last year, I did about 80% minimally invasive, and there were 1 to 3 levels. And it's at that point we had the opportunity to start doing more extensive cases using the robot, because it made it easier for us and safer. This is a expandable tube. This tube was made by a company called Endius, and this came about in the very late 1990s and early 2000s. And so with it, and it went through several revisions, but with it you can make a 3-centimeter incision, but then the tube opens underneath, much like an umbrella would open, but facing down. And so actually through the tube itself, without a percutaneous system, you can place any pedicle screw. It was nice and it worked well for a while, but it was difficult for a lot of people to become accustomed to. And so I became interested in, of course, along the way, doing anything I can to become more minimally invasive. And so with regard to the robot, at this point we've done over 100 cases, and I started because with the robot we can decrease the intraoperative radiation and we have better accuracy. And so now, with the change in my practice, last year we've been 100% minimally invasive, no matter what the size of the case. And so today we'll talk a little bit about minimally invasive surgery versus open. I'll go through some case studies. We'll talk briefly about the pathology, indications, and patient selection. This first case is one in which the patient had a previous right side decompression. He then developed left-sided symptoms after having done well for a while, and then recurrent right side symptoms. And so we used a combined strictly percutaneous approach, and this is a 4-prong retractor through which we approached on the contralateral side. Here are some x-rays. You can see the retractor in place. This is a stick shift going down through the pedicle. And this is nice because it shows that when we're doing this, whether it's through a tube or whether we're placing a gem sheeting needle to place the guide wire on the lateral, when we see that at the very back of the vertebral body, and not shown here but in the subsequent picture I'll show you, when it's in the middle of the pedicle like a bullseye and back there, that's the perfect position. So we're completely confident that that's where we want our pedicle screw and or guide wire to go. In this particular case, we applied them percutaneously. Here's a couple of guide wires. An interbody spacer has already been placed there. And then once again here you can see approaching with a gem sheeting needle prior to placing that wire. And then post-operative x-rays look okay. Here's the interbody spacer, and again through 2 very small incisions. So really that's freehand spine surgery, and it really is safe and successful, but we've heard this for many, many years. It has sort of a undeserved bad reputation. Everybody, I haven't met anybody who hasn't told me, oh, you should never have back surgery. So-and-so told me you should never have back surgery. And so, although the technology has changed, certainly MRI has made things a lot safer, a lot more effective, and MIS has, what people know, what the patients know, really hasn't caught up. And we do clearly have anatomical challenges. I don't know about you, but occasionally we run into that difficult pedicle. You're doing a long construct, and one of the pedicles just gives you a hard time. I didn't know why then, but now, having used the robot, we get preoperative CT scans, and there's some very weird-looking dysplastic small pedicles out there that look fine on X-ray, and you would otherwise not know it. And those are the ones which can be difficult to navigate. And because of that, probably big studies of some of the best spine surgeons, 10% of our screws are outside the pedicle sometimes, and some of these, 1% maybe, can cause permanent nerve damage. And so anything we can do to decrease that, of course, we're interested in. And then we also know that as orthopedic surgeons, we're more likely to get thyroid cancer, about 25 times more likely than other surgeons and other people. And then as minimally invasive guys, we get a lot more radiation exposure. In fact, that's one of the reasons why some guys say they don't want to go to minimally invasive, because of all the radiation exposure. But 15 years ago we didn't have data, but now we do. Minimally invasive surgery really is a nice option. It's really a philosophy of an approach to the spine. It's not one set of instruments or implants, but it's a combination of skills, interest in learning more skills, and the implants with access platforms, techniques, and expectations too, expectations on the part of the surgeon and of the patient. Early on in 2000, when we were doing a lot of dilating off midline, we needed some information. So this group of surgeons, including Todd Allman, did a study where they passed dilating tubes to muscle and they measured pressures. And obviously, the pressures are much less on the muscles than if you strip them off the middle of the spine and put big retractors on them and hold them apart. We're doing some iatrogenic damage sometimes with these retractors, particularly in longer cases, which wasn't seen with dilating tube approach. And so that's why I personally feel like anything off the midline, anything with an expandable tube or a dilating tube, gives the patient a better chance of losing less muscle in the long run. Along with this study, there were a couple other studies which were published. One was showing that EMG evaluations of the paraspinal musculature, of course, is weak even after microdiscectomy, but it's much weaker than if you do a midline versus a tube approach. And then there was another MR study where they looked at special sequences, asking the question, are there differences between 1 and 2 level open and minimally invasive? And very clearly, with a 2 level open, inflammatory changes extend another couple levels above and below where the surgery is. And so it's no surprise that down the road we see patients come back and they've got atrophy of their paraspinal muscles, and they've got the typical kind of failed back pain syndrome. So the things we can do, of course, there's a wide variety of options in minimally invasive. Mainly, we like to get off the midline, but we can do endoscopic approaches like something like the Joymax approach, where we put a little tiny tube in, which is great for far lateral disc herniations, and then we can have strictly percutaneous techniques. Percutaneous screws with fractures work well, but you can pick and choose. There's a lot of different options in terms of 3 or 4 blade retractors, distally expandable tubes, constant diameters, and I think part of the process is to find out what you like and what works well for you. So if we talk a little bit about minimally invasive surgery without the use of robotics, it has obvious advantages to open surgery. I used to include a lot of references in my slides, but now, right now, you can just pick up your smartphone and Google this and find out the data, and clearly there's less pain, less blood loss, and less narcotic use after minimally invasive surgery. So people walk faster, they have shorter stays, or it can be outpatient. It's really well received by patients. They like the idea. It gets away, I think, a little bit of the misperceptions about spine surgery. When they know it's not a, in quotes, big open back operation, psychologically they're more amenable to having it done, and they've reached the point where they really need to have surgery. They've tried everything conservative, and so if they go in with a positive outlook, I think it can't hurt, and certainly I think it helps. I read last year that only about 13% of spine surgeons in the U.S. do minimally invasive. Yeah, I was surprised, because 10 years ago, I was thinking, it's got to be 15%. Next year, I'm thinking, it's got to be 20%. But I didn't really was growing very much. And the interesting thing is that a lot of surgeons say they're minimally invasive, but a lot seems to not. And of these 13%, it seems like most of them in the U.S. and from what I can understand are in Florida and Texas. Why? I don't know, but there's big geographic variations in what people do, and how they treat the variety of problems. In 2011, at the ESPIS meeting, they polled and they published this information on why surgeons don't adopt minimally invasive surgery. Radiation exposure, 32%. Lack of training and technical difficulty, pretty high. Lack of efficiency. And so really, more than half of the barriers were really related to education and application. And so I think that's part of what we're hoping to do, is to bring to people the education and tools that they need so that they can realize some of the better outcomes that are available. There are definitely perceived disadvantages, which we can show data. It's not true. It takes longer. Sure, there's a learning curve. It could be 2 cases, it could be 20 cases, depending on the person. You can't get a good fusion or a decompression. It's just not true, and we can show data that. And technically difficult? Well, maybe it is until you get the right training and put some time and effort into it. I would say that the results are well worth taking the time to get past the technically difficult aspect. I think the only real disadvantages of minimally invasive is the increased radiation exposure, and it's still freehand. In that freehand, we can get about 90% of screws in the pedicle, and there are some options to help us do better. But using the robot, I think, it overcomes 2 of those problems. It decreases the radiation exposure, and it helps us get better screw placement. So now, probably on simple 1 and 2 level cases, for MIS, you're not dealing with bad deformity. So I would suspect, I don't know, but when your screw's not in the pedicle, it's probably more of the complex cases, right? And so I think it's very reasonable for spine surgeons to start to adopt this, and there's no need for the robot, especially on those 1 and 2 level cases. And even if you're going to use the robot, you need to know how to do it without the robot in case something happens, right? So real MIS cases, guys really want to start with whatever implants or whatever type of access platforms they need to go ahead and get started and feel comfortable. So what the robot can add is the robot has been shown to be safe, successful. These are all less pain outpatient. These are all, of course, just about MIS, but the anatomic challenges are minimized. We look at that pre-op CT scan, we see the spastic pedicles, we plan our screw lengths, diameters, angles, and allows us to navigate past those difficult anatomic positions, knowing what's there ahead of time. It really does take a lot of the stress out of that. And then there's a lot less radiation, of course, which is great. And that overcomes some of the barrier to entry, maybe for some surgeons. And then there's an improved reputation. You know, I think the old saying is don't ever have back surgery, and we're hoping to be able to bring all these techniques forward so someday maybe we can say don't ever have open back surgery because you'll get that result. So the indications for our minimally invasive surgery are the same as open surgeries. As we spoke earlier, we're doing the same thing we're doing open, but we're just doing it in a different way so we don't affect the tissues in a negative way. And whatever you've done in the past, however you like to do things, dictates how quickly you move forward with it. I probably wasn't doing half of what I'm doing now minimally invasively in my first 5 years of starting, but I was also pretty much by myself. There were some other guys out there, but it was early on. We didn't have all the tools we have today, so you can pick these things up and get the experience you need very, very quickly with everything we have available today in terms of access platforms and implants. So the robot offers us the availability to place the wires very easily and safely. It takes a lot of the stress out of the operation and reduces the radiation. And you can also use it for planning decompressions and fusion. It's been used for other things. Here's an example of an 87-year-old gentleman. He came to me after hearing me talk about SI joint pain. And he came in, we took these x-rays, and he wanted me to fuse his SI joint. I said, I can do that, but it won't help you. I said, why don't I fix this? And he was agreeable that I showed him his x-rays. And so he's got very bad, this is quite mobile. Also, he had some previous surgery before, and so maybe that led to this spondylolisthesis. CT scan showed look at all the reactive bone here that we have in this cupping, right? Cupping, and look at the osteophyte over on this side. So we went and approached him with a lateral approach, placed interbody spacers, and did a great job just with the interbody spacers of reducing the spondy, and also, of course, regaining height and restoring some of his normal lordosis. And so we placed the screws using the robot in that case. This is just an example without a lot of detail about how you can do 3 levels. 75-year-old anterolisthesis noted here, a multi-level stenosis. Here we can see his MRI. You can see how tight he is. A lot of degenerative reactive end plate changes. Here are the 3 levels. This is 5-1, 4-5, and 3-4. You see how tight that is. The facet joints are a bit loose. You can see some effusions in the facet joint going along with the spondy at L3, L4. And then just the end result here, interbody spacers. We chose to do this gentleman completely posteriorly, so we did T-lifts at 3, 4, 4, 5, 5, 1, and decompressed them and then placed our screws and rods. 4 levels, also easily approached here. Here we have a grade 1 spondy, L4 and L5. He had multi-level stenosis, pretty severe stenosis at this level, not so bad down here at L5S1, facet ligamentum hypertrophy. And so we addressed all of that through tubes, doing decompressions, and then instrumented. He had a combined approach of 2 interbodies placed through a lateral approach, and this is one of those situations where the risk-benefit ratio of doing a lateral going through the psoas was too high for me, so we just did a T-lift when we turned him over, and we completed the instrumentation from posterior. So in terms of planning things, there are a lot of options. This is an example of a patient, of course, with a lot of what we've been talking about, degenerative scoli, and so we straighten them out quite a bit, just by putting these interbody spacers. So we did a lateral approach at L1, L2, 2, 3, 3, 4, and L4, L5. Now he has a much better alignment of the sagittal and coronal views, and so we went ahead and used the software of the robot to plan our screws, plan the length, plan the diameters, and plan the incisions as well. Here's our pre-op planning lateral and AP view. You notice now that there's no spacers here because this is our pre-op CT scan, but it doesn't matter because the robot registers independent vertebral body. It's not navigation, it's completely different. So the robot still knows where everything is, so even though that's not what the spine looks like now, it just stacks the vertebral bodies, and so we're able to place our screws and rods. And here they are, the screws and rods across that longer level construct. Just to show how on the planning we can back out this green line where the screws are, and the planning software shows these screws as though they have the tube extenders on them, like the integrated extended tubes that we use at this point with Medici. And here we've grouped all the exit points in the skin in an area where we can minimize the length of the incision. We don't always get to keep it this small because we need to pass the metrics tube, which is not very big, but we sometimes need to enlarge it just to do our decompression. What I don't personally like is just a personal pet peeve. I don't like having to enlarge my incision to put screws in. Some of the percutaneous screw systems out there are quite large, and they have intricate mechanisms and they work well, but I like to keep things small, keeping in line with sort of a minimally invasive approach. Here, as an intraoperative photo showing anesthetic going in where we planned one of the incisions, the dilating tubes with the robot. This, of course, is a hover T-frame. And then this particular case was planned preoperatively. And so there are a number of different platforms which we talked about some of the time. We talked earlier, what do doctors like to do? Put screws in first or decompress first? And so it doesn't matter. If it's MIS, we still do just what we like to do, but we just change the approach. So you can keep doing whatever you want. We never ask you to change anything in particular. An example of placing the hover T-frame, we just mark the skin over the PSIS, anesthetize it, 2 wires going over the PSIS, and then a spinous process. Here the hover T-frame is in place, and we have our guide there to coordinate and correlate our 2 X-rays, AP and oblique, with the CT scan. We talked a bit about draping. So here we have multiple wires up and down draped out just to keep them out of our way. Once they're all placed, then we go ahead and move forward with the decompression. And so there may be a lot of different ways to do decompression. As an open surgeon, I would decompress starting under the lamina. I'd put my Woodson in, strip the ligamentum, start taking bigger and bigger bites, and then come on out here, start doing my fascectomy, get under the medial board. So it would all be from inside out with the Carson. There's also a translaminar approach, which my partner does, in which he uses a drill and slowly drills a cylindrical hole through the lamina until he sees ligamentum. Then he takes his Carson punch and starts to work out laterally into the area of the facet joint. There's the transfacet approach, which I've been using most recently. And so, of course, this is not a very hypertrophic facet. They can be quite large. So I will dock my dilating tube onto this and then start drilling down. And then I watch that little facet joint. As that facet joint curves down and comes out under the medial border here, then I know where I am, I know where the spinal canal is. I can continue using my high-speed burr and enlarge the opening. So I will do my partial fascectomy, partial laminectomy. I then do a foraminotomy. Then if I'm going to, I do my interbody work. And then lastly, if I'm decompressing the other side, I tilt my tube down and I reach all the way across the other side. I only do that really for moderate stenosis. If it's severe stenosis, then we approach it bilaterally, just because it's much more efficient, I think. Sometimes when we want to do interbodies or osteotomies, I'll actually, under a lateral x-ray, go ahead and just place my osteotome at the inferior border of the pedicle and just cut right through. And then same thing down here, just cut right through right above the pedicle and then just pull the whole facet out by doing a total fascectomy. I have found for me, in my hands, if there's previous surgery in here, instead of trying to tear that scar tissue off and carefully dissect it away, if I just start out here and start working this way, for me, it's easier to just lift up that portion of the facet and it comes out this way. Just pull it up the dorsal, and for whatever reason, for me, I hold it with a pituitary, I use a little angled thread, and I can just dissect that scar tissue off the facet joint and it comes out. So redos are not a problem, just take a little bit more care, maybe change the way you do your decompression, but because there's hardware there, because there's a redo there, does not mean you can't do the whole case minimally invasively. Just an example of these things in place here are our 2 dilating tubes. All of our wires have been placed, of course, and here my partner and I are working simultaneously. He does his translaminar approach, and I do my transfacet approach, and everybody's happy. We always check the position of the wires on the AP view. These beads, of course, are from the markers that we use on the X-ray, but you can see from the right-hand side, this pencil is crossing over into the area of the framing on the contralateral side. Once we have the screws in, you can see here Medici screws in place, which have I call it an integrated tube extender. It's really part of the tulip. And so once they're all in line, we pass the rod percutaneously, and this shows an example of the driver with basically a slip-type clutch so that we can quickly pass those screw caps down inside. We estimate the length of the rod by eye sometimes. Sometimes we use calipers, and then sometimes we use the software with the robot. And then we do our bending by eye. There, of course, are other options. There are mechanical benders that you can try from various companies, but but so far we haven't used anything. We just carefully bend it by eye, and then pass the rod through the tulips, looking down the tulip to be certain that we have passed through each screw, and then also that we're below the fascia and the muscle. Just an example, of course, of rod bending, and this is one way to estimate the length of the rod. This is a type of inserter where we make the incision and then it comes down and it's not pass down. And those, for me, that's very effective for longer constructs. Here we have, my partner's passing one yin-yang style. He's going up with his rod, I'm going down with my rod, and we're passing them simultaneously. So, in terms of bone grafting, we do the interbody fusion, we can do post-roll fusion. I think the thing is really just do what you do open. It's not as easy, of course, because you have to be a little more creative with retractors and make sure that you're getting decortication of the transverse processes, of the lateral aspect of the facet joints, or whatever you want to do, but just do it like you do open. And then planning can be important as well. Sometimes we stage these bigger cases if they're in their 70s, they have multiple medical problems. We're doing a 3 or 4 level A-lift. We'll do that on a Tuesday, we'll let them rest on Wednesday, we bring them back and do the remainder of the procedure on a Thursday. This is a more detailed example, a 77-year-old who had classic neurogenic claudication, currently walked 2 blocks, tried, of course, all the usual conservative care, and it's a medical problem. So his x-rays, of course, show here a spondyloL4-5, virtual aesthesis up here, multi-level degenerative disc disease. He's got this gentle curve concave to the left. MRI shows multi-level degenerative changes, stenosis here at 4-5, disc bulging here. The axials show the stenosis a little bit better, really not much room in the canal at all. Facet fusion here going along with his spondyloL4-5. And so we first approached him with an anterolateral approach, with placing interbody spacers, and then followed up as stage 2. Again, here you see our wires in position, being draped out of the way. Example of the dilating tubes being put in to show a sense of scale where the wires are and how we achieved all that decompression that we needed to, and minimally invasively. So these longer constructs can easily be done minimally invasively. It's just a matter of having the interest and the time and the patience to go ahead and pursue them that way. Personally, I would much rather do patients who are larger BMI or patients who have difficult anatomy. I'd rather do it MIS because it takes a long time to do a good exposure, right? And then I know what I'm doing to those tissues as I do that kind of exposure. Just to show a combination of different types of retractors. On one side, my partner is using that 4-blade retractor in a paraspinal manner, and here we see a smaller metric start to achieving a decompression. And so he has this technique with his drill on that side, and then this is him on his side. He's decompressed my side. I'm on my side. I've decompressed his side at that level. So if you have the luxury of being able to operate with someone who likes to do what you do, these cases can be speeded up, of course, by leapfrogging and combining, and it's a lot more fun to work with someone that you like also. It gets a little hectic in the operative field. Here we are, we've got our drills going, passing the tap back and forth, passing the screws back and forth, while looking at x-rays, but it gets the job done quickly. Power can be used very, very safely and effectively, and certainly can shorten the case, making it better for the patient. If you can place, 18 pedicle screws in 20 minutes with guide bars, rather than maybe an hour or something like that. Plus, you just get tired, turning that many screws in, right? So we always check an AP view with the screws in place before we pass the rods, and again, passing the rods here, up and down, putting our screw caps in through the tubes, and then checking the lateral and final AP before we snap off the tube extenders. There's a final X-ray for that particular patient. And then these are immediate post-op pictures. And so 1, 2, 3, 4, 5. So that's about 5 centimeters long, maybe 2, maybe 1.5 here. And then these little small openings for replacement of the pins for the robot attachment. So really, I think your surgical expectations can be the same fusion rates and decompression results as you get with open cases. With the robot, you can anticipate overall better screw placement, particularly in my opinion on the longer, bigger constructs, the 1 and 2 levels with healthy people, good bone, no dysplastic anatomy. I think our screw placement is very good freehand there. But clearly, you can save on radiation exposure and have shorter OR times using some of these techniques.
When we are starting to do minimally invasive, normally we think in 1 or 2 levels, but now we are look at different multi-levels. Yeah, but if I think about that, I think it's very difficult to do multi-levels. What is the tips for do surgery in multi-levels?
What do you find? What do you perceive as difficult about the multi-level?
The difficult is the rod. You have to,
Okay.
you know.
All right. Yeah. It seems like it's difficult, I think, until you try it, until you have some practice. And so, certainly having the opportunity to pass some rods on a cadaver, in a cadaverics, in an instructional setting is a good confidence builder. But, I think you're comfortable with 1 level. There's several ways to get the rod down there. 2 level, 3 level, you start to pass it through the tulip heads. When you get confident with 3 level, then do a 4 level. When you're confident with 4, do 5. Yeah.
And then 9 levels.
And then 9 levels, right. And so then it's just a matter of using your eye to determine which kind of bend you want, where you want, the appropriate lordosis, how much kyphosis to bring over the top.
Okay.
And of course that's dictated by the patient, what's normal for that patient and the patient's spine. And so by comparing your pre-op x-rays with how you want it to look, bend it to that curve, and then you pass it percutaneously. And as we saw with these screws, the threads go up about 3 centimeters. So as long as you're under the muscle, under the fascia, the screw caps help seat it in. So it's not as difficult really as you might think it is. It truly is not.
But normally you have to do bend of the rod.
Right, yeah.
Okay.
Yeah, I would tell you honestly, I think in most of the 1, 2, and 3 level cases, we don't do much rod bending because we use pre-contoured lordotic rods, and they're a very average lordosis. Sometimes we take a little of that lordosis out for people. Sometimes we put a little bit more in.
Okay.
But it's just a matter of, typically what you would do if you're doing, T10 to the sacrum open, you're bending that rod, and so you do the same thing as you used to do open, but you're just sliding it percutaneously.
Yeah. In your course of learning, what is the most famous complication about this kind of surgery?
Yeah. I think the most difficult thing, in my experience in working with surgeons, is to really just to get them to go to training and apply it, and take that step of doing that first case. That's the most complicated part. Sure, you'll run into the occasional dural tear, but it's a dural tear. We're all used to fixing those. Is it a little more difficult to sew it in a tube? Sure, it's a little more difficult, but it doesn't happen often, and it's part of the risk. But I don't think there are any specific things that are any different than open.
Okay.
They're really